Ventricular septal defects. Ventricular septal defect is a congenital cardiac malformation in which there is a hole or communication between the ventricular septum. It is most common congenital heart defect after bicuspid aortic valves. The VSDs are classically broken into subtypes based upon their embryologic and anatomic landmarks, and there are several classification systems and they can be classified both on the basis of location and bordering structures. So it can be classified into types 1, 2, 3, and 4. Type 1 is outlet, which is conal, subarterial, and supracrustal, and this defect is located beneath the pulmonary valve annulus and results from the failed formation of the muscular pulmonary infundibulum. Type 2 is perimembranous, perimembranous, and conoventricular are subtyped. They are 80%, formed when the membranous area of the septum fails to completely develop and is adjacent to the commissure of the anterior septal leaflet of the tricuspid valve. Type 3 is the inlet atrioventricular canal, endocardial cushion. Various forms of the inlet VSD exist. However, the most common is the defect, quite similar to the perimembranous defect, and this is immediately below the septal leaflet of the tricuspid valve. And type 4 is the muscular. It is 10%, and they can occur anywhere in the muscular interventricular septum. Pathophysiology of the VSD is defined by the amount of the flow across the VSD, and this is determined by the relative ventricular compliance and the contractile properties, as well as the balance between the pulmonary vascular resistance and the systemic vascular resistance. At birth, PVR is high. However, PVR falls over the first several days of life and continues to decline for 4 to 6 weeks at birth, and blood exiting the left ventricle and preferentially choose the systemic circulation due to its relatively low resistance, and the PVR fails. A portion of each stroke volume being the ejected by the will flow across the VSD and return to the pulmonary circulation, and increased flow correlates into the increasing murmur on the physical exam that may not have apparent at birth. The amount of shunting from the left to right is determined by the size of the VSD and the resistance within the pulmonary vasculature. If the shunting is significant, the neonate may present with the signs and symptoms of congestive heart failure, which can include failure to thrive, tachypnea. When eating and sweating on physical exam, one can appreciate the pansystolic murmur, hepatomegaly, and tachycardia. Paradoxically, the louder the murmur, the smaller the VSD, due to increase in velocity of the small VSD. The QP to QS will be greater than 1 and can rise up to 2. Increased flow through the pulmonary bed leads to pulmonary hypertension and increased PVR. Increased PVR leads to elevated right ventricular pressures and right hypertrophy, and eventually there can be reversal of shunt flow. The end stage phenomena is termed as Eisenmanger Syndrome. The chest X-ray may show cardiomegaly with increased pulmonary vascular markings due to increased QPQS, and lung fields may appear congested. ECG will demonstrate the left and right or biventricular hypertrophy, but this is not diagnostic. Echocardiogram, diagnostic modality of the choice, shows an abnormal flow across the ventricular septum. Doppler and pressure measurements allow for estimates of QPQS and filling pressures that help to determine the need for surgery for further diagnosis. Cardiac catheterization, while the excellent to obtain the diagnosis, and this is not the initial study obtained due to the invasiveness, and nevertheless, the patients who present late or at risk of fixed elevated PVR, a cardiac catheterization may be performed to determine the PVR and its relative reversibility. The important contraindication to repair is development of the fixed pulmonary hypertension, PVR greater than 8 Woods per unit that does not decrease the inhaled nitric oxide or 100% oxygen is a contraindication to surgery. The initial treatment of choice of VSD is medical management of congestive heart failure. The goal of medical management is to allow the time of VSD to close spontaneously. The spontaneous closure of the large non-restrictive VSD is unlikely after 6 months. A smaller restrictive VSD may close spontaneously throughout 12 to 18 months. Catheter-delivered device closure can be used with a muscular and certain perimembranous VSD, and these devices can be delivered either percutaneously, paraventricular, in a hybrid approach. Complications include device embolization, heart block, residual defects, and vessel thrombosis. Surgical repair. The timing of the VSD repair is a controversial topic. Currently, indication of the timing of repair is as follows: persistent symptom despite maximal medical therapy such as persistent CHF, respiratory infection, and failure to thrive. No symptoms but pulmonary artery pressure greater than 50% of the systemic by the end of the first year of life. Recurrent bacterial endocarditis regardless of age. VSD with residual resultant aortic and pulmonary valvular pathology should be repaired shortly after the diagnosis is made. Patient with persistent defect after 1 to 2 years of age should have their VSD closed. It is unlikely that these VSDs are spontaneously closed, therefore repair is undertaken to prevent the complication of left to right shunting and endocarditis. The surgical approach for the repair of VSD is dependent upon the subtype of VSD and the presence of any additional heart pathology. Access to the heart is through the median sternotomy. The typical VSDs are approached from the right to left atrium and the tricuspid valve and the right ventricle. The VSD is typically repaired with a Dacron PTFE or autologous pericardial patch. Suturing of the patch in place must be done carefully to avoid the damage to the aortic and pulmonary valve leaflet, the tricuspid valve apparatus, and the conduction system. If multiple muscular VSDs are present, the largest holes are closed while the small holes are left open and allowed to close spontaneously. This approach may be coupled with the placement of pulmonary artery band to facilitate the closure, while a higher right approach is typically adequate. Transaortic or right ventricular or the left ventricular apical approaches have been described for a specific anatomic consideration. Outlet or supracrystal defects are typically closed through the pulmonary artery, and close attention must be paid to avoid the bundle of his that descends below the membranous septum and closing perimembranous or inlet VSDs. Repair of the VSD in the modern era is safe and reliable. The major complications of the VSD repair are incomplete closure with resultant left to right shunting and complete heart block requiring the pacemaker. Mortality is less than 1% at the expense of experience of center. Thank you very much.